Did you know that a woman dies of pregnancy or childbirth every 2 minutes in today's world? WHO estimates that over 90% of maternal deaths occur in low-resource settings. These regions often grapple with healthcare issues that are not limited to, but are massively dedicated to the shortage of healthcare professionals and limited diagnostic infrastructure. That's where the BabyChecker comes in. Hello, everyone. Welcome to Delft Imaging's first ever BabyChecker webinar. My name is Katyayini Singh, and I will be your host today. We are fortunate to have a panel of esteemed speakers who will dive deep into today's topic, that is AI-powered pregnancy screenings in low settings, low resource settings, BabyChecker, and beyond. Before I introduce to them, let us note a few instructions. Next slide. This webinar is simultaneously interpreted in French, Spanish, Russian, Arabic, and Portuguese. So make sure that you click on the interpretation button to select your preferred language. Additionally, there will be a Q&A session in the end. So please make sure that you leave your questions in the Q&A box instead of the chat box. Thank you. Next slide, please. I'm pleased to announce today's speakers. We have Mr. Karlin Bacher with us. He's the Director of Clinical Quality Improvement in the Jericho Road Community Health Center. We have Ms. Sofia Sappia, the PhD candidate in the Medical Imaging Department at Radboudumc, UNC. Next, we have Ms. Irene de Vries. She's a maternal and newborn health advisor at the Kit Royal Tropical Institute. And last but not the least, we have Mr. Jose Perez, the UNFPA representative in Honduras. Next slide, please. That's not all. We have our very own Florent Geerts. He's the business unit director at Delft Imaging. Alongside him, we also have Julio Lopez, who is the deep learning lead of the BabyChecker. So without any further ado, Florent, the floor is yours.
Yes, perfect. Thank you, Katja. Yeah, just fixing the echo on our side. Thank you, Katja, for the introduction, and good morning, good afternoon, and good evening, everybody, for dialing in today. Thank you so much for that. And like Katja mentioned, to all of the different speakers that are involved in today's webinar. As you might know, as Delft Imaging, we organize webinars on a quarterly basis, but most of the time, our focus is for those webinars on TB and tuberculosis and lung health. This is the first time that we're focusing that specifically on maternal health. And of course, the topic for today, AI-powered pregnancy screening in low resource settings. So if you can go to the next slide, please. Because the first time that we're doing this specifically with the topic of maternal health, I wanted to give a very brief introduction about us and how we've arrived at this webinar before we go into the different speakers. As Delft Imaging, we're a social enterprise, meaning that at the end of the day, our goal is to really have impact in those countries that we are active in, which is about 75 countries around the world. And some of the aspects that you see here, like UN Global Compact, the different sustainable development goals we work with. Also, we're a certified B Corporation, which is like an ISO certification, but reflecting really societal and environmental impact. And we're also proud to be a member of the Million Lives Collective, which recognizes those organizations that have impacted over 1 million people around the world living on less than $5 a day. The reason that we are very proud also to be a certified B Corp and part of the Million Lives Collective, because it really reflects our focus and the importance that we have on our solutions and how they are aimed for impact. And I think you also see that in the solutions that we have. If you can click to the next slide, please. Our specialism is really in artificial intelligence and imaging and the way that they can enhance accessibility to care. And what we're very known for already is, for example, our portable X-ray systems, like you can see here on the left side, our Delft Light backpack X-ray, which fits within a backpack. You can take it with you to the remote locations of any country, like you can see here, it being used in Uzbekistan. Or like in the middle, our Cat40B artificial intelligence software, which was also endorsed by WHO back in 2021, which uses artificial intelligence to screen and triage for tuberculosis. But then, of course, for today's webinar, we're all talking about what the application is of ultrasound imaging and also artificial intelligence and the good that it can do in maternal health. And so that will be the scope of today. And if you go to the next slide, please, with all of those activities that have brought us, like I mentioned, to 75 countries around the world, where we work with technical agencies, with funders, and with implementation partners on the ground to implement all of these projects in the field of imaging and also of artificial intelligence. As such, we do that with in-country partners. We have partners basically in every country to support activities on the ground, but also with our own offices like in Ghana, in Nigeria, and Indonesia, and of course, where we are based here at our headquarters in the Netherlands. And we're very proud that with all of our solutions, we've been able to impact over 20 million people around the world. Next slide, please. Yeah, so what we will be talking today is really point of care ultrasound and specifically about the BabyChecker. And the scope of this is like what I mentioned on X-ray and AI imaging. It's really about low resource settings and the good that it can do there. So as you saw, I think on the previous map before, the scope of our projects, it's not in the EU, it's not in the US, it's really what we can do in low resource settings. So for example, here using the BabyChecker, which my colleague Julio will talk about later on, being used in Sierra Leone. And even in that scope, again, in countries like Sierra Leone or in Kenya or Ethiopia, our focus is not, the larger hospitals within the capital cities, really focusing on those clinics in remote areas where it can do most of the benefit. So this was a short word of welcome from my side. I'm very pleased to have all of these great speakers here today. I'm very glad that we have this first maternal health webinar, which I'm sure will be the first of many. And I'd like to give the floor to our next speaker, my colleague Julio, to take us through a bit of the work that we've been able to do on BabyChecker. Thank you.
Well, hello, thank you very much everyone for being here to the very first of the BabyChecker webinars and hopefully also the first of many. Well, first of all, I can't start talking about BabyChecker without mentioning Delft Imaging and the journey we have been through. We are pioneers through history. We've been working, focusing on computer aided diagnosis devices, like from a long time until now already, and focusing mostly on tuberculosis, but lately we are also focusing on having safer pregnancies and detecting those risks. Like if we go to the next slide. Well, Delft Imaging, as Florent already mentioned, it's present in several countries, in more than 75 countries, and have impacted a lot of lives already. BabyChecker journey has just started. But we believe that the impact and the potential that can have in different countries and in lives, it's the same or the same as the one that we are currently doing with Cat4TV. And for now, we are focusing mostly on sub-Saharan Africa, and thanks to our colleagues from the UNFPA Honduras, we are recently also in Central America, in Latin America. We go to the next slide. Now, this innovation has come in a world where maternal health disparities still exist. There is a big gap in access to essential services that can mean the difference between life and death. So if we, in the next slide, please. So BabyCheckers comes from this reality that there is more than 800 women that die from preventable causes related to pregnancy and childbirth every day. 99% of these causes are in developing countries. And 90% of those maternal deaths can be prevented. Like the WHO endorsed ultrasound as a technology that can actually improve pregnancies, make them safer. It can be used for detecting gestational age, for detecting localization, the placenta localization, fetal presentation, and other risk factors that can really impact and make a difference in a pregnancy. However, if we go to the next slide, ultrasound still remains a luxury. It's only available to 6.9% of the women in sub-Saharan Africa. And you will ask, why is this the reason if it's endorsed by the WHO and it actually can help improving making pregnancy safer? Well, the main thing is two reasons, like the prohibitive cost of traditional ultrasound and that there is a big scarcity of trained sonographers. Only 38.8 trained sonographers have only 38%. There is 38.8 trained sonographers that don't have training. Okay, so if we go to the next slide. Now, to support these claims, we can see, like, imagine that you are a pregnant woman, 6 months pregnant, and you have to take a 2-hour bus to get an ultrasound. How will that make you feel? Well, this is one of the midwives in one of clinic in Ghana that is telling us that in order to make a real impact, we need to bring this ultrasound technology and to the point of care where it actually makes a difference. Therefore, BabyChecker, if we go to the next slide, BabyChecker is here to bridge this gap and really make an impact, empowering health workers in primary healthcare to make pregnancy safer. Next slide. Now, what is BabyChecker? Well, BabyChecker is a smartphone-based ultrasound that uses artificial intelligence to identify risky pregnancies, improve timely referrals from primary healthcare facilities. Next slide, please. Now, again, click, please. So BabyChecker journey hasn't started yesterday. We've been on this for several years, starting from our research till the product that we have right now. At the beginning, we thought about making our own ultrasound. That wasn't the way. We decided to don't reinvent the wheel, but instead of doing that, we want to make the wheel move smoother. Therefore, we have several publications that validate BabyChecker results and the BabyChecker viability. Next slide, please. Now, how does it work? Well, BabyChecker uses the obstetric 6-sweep protocol. This is basically a 6-sweep, and you use the ultrasound probe to make a 6-sweep, and it is able to, with that, we are able to detect different risks, like, for example, the gestational age, the fetal presentation, multiple pregnancies, the placental location, or even the fetal heartbeat. Next slide, please. Now, BabyChecker, it's created for resource efficiency. We know how hard it is to train a sonographer. Therefore, we ideated BabyChecker to make it easier for them to be able to use it. It requires maximum 1-hour training. We have a video tutorial in the application that is self-explainable and allows everyone to use it. And it doesn't require prior experience. Like different places where we are currently in Africa, for example, they have never seen an ultrasound. So we need to make sure that the application and the device can be used without any prior experience. And also there is no constant power required. Also, if you want to make an impact in the places where there is no ultrasound, you require something that also doesn't require constant electricity. Therefore, currently BabyChecker uses only the power of the phone to be able to scan a pregnant woman anywhere. Next slide, please. It's also an easy to use application. The same as with the power issues that there is in developing areas, like there is also internet issues. And in order to make this application work, you need to be able to use it without internet, without any connection. Therefore, it functions offline. The results for artificial intelligence comes within a minute. And also, we currently support multiple languages. To the moment, it's English and Spanish, but it's really easy to add different languages as well to the application in the future. And we are planning on that as well. Next slide, please. And where do we bring the value? Well, the value here, it's like we are focusing on the community health centers and the outreach projects. Like you are able to bring the BabyChecker device, which is fully portable, to here and perform a BabyChecker scan. BabyChecker scan currently have a traffic light system that is green, yellow, or red. Very easy to understand. Everyone knows how a traffic light system works. And based on these colors, let's say like that, we can decide if there is a need to schedule a next visit or there is a need to refer that pregnant woman to the hospital to be carefully examined. Next slide, please. Now, as I said, this hasn't started yesterday. The research and development started back in 2017. We initiated it with the Delft Imagine and Radboud University, thanks to a PhD thesis that now we are continuing, and we have also here today Radboud University representative to talk more about it. Till the moment that we are now, that we are finally in a go-to-market situation. We have the early adopters in Africa and Latin America, and we are very happy to be already impacting people's life using BabyChecker. Next slide, please. We are part of Delft Imagine, but within Delft Imagine, it's a small team that is currently doing BabyChecker. We are focusing full-time on developing both the artificial intelligence, the business areas, and the Android application in order to make everything work smoothly. And this is the team that we currently have with the new additions lately of Akshay. Next slide, please. Of course, we also need to thanks to our partners, because without them, BabyChecker wouldn't be here the moment that there is, and we wouldn't be in this exciting moment where we can really bring BabyChecker and start expanding more and really impacting people, pregnant women lives. Next slide. Finally, well, I am really excited about BabyChecker, and I hope I could transmit part of this excitement that I have from doing artificial intelligence and really bridging this gap between technology and healthcare to you. And I will be really looking to move forward together, impacting women's life and improving healthcare in general. Thank you very much. Next slide is the end of the presentation.
Thank you. Thank you so much, Julio. I'm sure everyone's very excited to be a part of the BabyChecker journey. All right, moving on, we have our first guest speaker. We have Mr. Karlin Bacher, the Director of Clinical Quality Improvement in the Jericho Road Community Health Center, which provides clinical care to underserved communities in the United States, Sierra Leone, the Democratic Republic of Congo, and Nepal. He's also a registered nurse with the experience of emergency nursing, global health, infectious diseases, population health, and quality improvement. Today, he will share his insight on using technology to leapfrog gaps present in global health. Hello, Karlin.
Good morning, good afternoon, good evening. Thank you very much. About 17 years ago, I started my healthcare journey, first as an ER tech and medical first responder, and later as a registered nurse in a busy US-based emergency department. It was a significant day when administration rolled the first portable ultrasound machine into our emergency department. As you can imagine, the response uptake from the emergency physicians was mixed. Some started using it immediately and frequently, especially as we treated our trauma patients. In my role as a charge nurse, I was often called upon to start difficult IVs in the patients we served. I started eyeing this new ultrasound machine. With the encouragement of one of our ED docs who worked the night shift, I started experimenting with it and using it to start IVs on patients with challenging veins. However, the use of the new and novel tool was short-lived. Bureaucratic administrators caught wind of what I was doing and quickly put an end to it, as there were no established protocols and an uncertainty of whether my nursing license covered the machine in this scenario. Fast forward about 5 years, and by this time, I've been living in Sierra Leone, West Africa for several years. At the time, the often quoted maternal health statistic was that 1 in 17 women were at some point in their life expected to die from a maternal health complication. At the time, Sierra Leone had the highest maternal mortality rate in the world. I'm not really trained in maternal health, but I'm a systems thinker and often found this issue to be overwhelming. During this period of time, I helped host a medical school professor from the Medical College of Georgia. He brought with him an exciting new tool, an ultrasound probe that could be plugged into a small tablet ultrasound technology in a relatively short amount of time had taken a tremendous leap. It was no longer a device contained to a single room or even a wheeled device that could be carefully moved throughout a department. Now the device could be easily transported all over the world in a small backpack. Also, the price point for the machine had suddenly become a lot more affordable. That week, in a short amount of time, the medical school professor did an incredible amount of imaging, looking at livers, lungs, abdomens, eyeballs, and even a few orthopedic injuries. He quickly convinced me that portable ultrasound was the diagnostic future of global health. My organization even purchased a device. However, we quickly encountered a major problem. The training requirements to operate the device were intense. We did have community health officers who started performing basic obstetric ultrasound scans and with time became decently skilled at it. However, when you have a staffing turnover, what happens? You're essentially back at square one. After 5 years of living in Sierra Leone, I returned to the United States. I was finishing up a graduate degree in international development and started interning with a leprosy-focused global health nonprofit. Within days, I was handed a research paper theorizing that portable ultrasound might be the key to subclinical diagnosis of leprosy, as peripheral nerve thickening happened to be one of the cardinal signs of leprosy. I was tasked to identify which companies were manufacturing portable ultrasound machines with the ability to assess peripheral nerves, investigate the price of the machines, and come up with a recommendation for a pilot study. As I looked into this, the limitation that kept tripping us up was the human skill factor. In order for this to be a viable, wide-scale diagnostic tool, it would need to be used more broadly than by a few expertly trained ultrasound professionals. At that time, I started asking the question, could AI solve this problem for us? I finished up my internship believing that AI could solve this problem, but unfortunately, even today, I'm not aware of anyone tackling this opportunity specifically related to leprosy. These key experiences of being exposed to bedside ultrasound use in the emergency department, seeing a well-trained individual doing an incredible job of leveraging the tool while working in global health, realizing that duplicating this ultrasound use was very difficult due to the need for a lot of training, seeing high maternal and neonatal death rates in Sierra Leone, and finally exploring how ultrasound could be used to diagnose subclinical leprosy created an ideal environment for dreaming about new ways of using ultrasound in global health. At some point, through the power of social media, I stumbled upon reference to some of the early work of the BabyChecker device in Sierra Leone. I was immediately fascinated. This device appeared portable, affordable, and also seemed to circumvent the need for specialized training. In early 2022, I reached out to Enya via LinkedIn to learn more, and was honestly a little surprised with how quickly and how warmly she responded. It was a bit of a process, but eventually I was able to get both approval and funding designated that would allow Jericho Road to start using this technology in our clinics in Sierra Leone. Our antenatal attendance rates have increased as patients love the reassurance and novelty offered by the scan. Recently, we were reporting out our antenatal numbers to a maternal health donor. They were surprised at these rates. In preparation for today's talk, I checked in with our nursing and midwife team in Sierra Leone to get firsthand stories about how they've been using the device. They shared the following two stories. At the beginning of August, a woman presented to our regular antenatal clinic for a visit. During the exam, they palpated that the baby's lie was not cephalic and that her belly was very large. They decided to use the BabyChecker device, which estimated gestational age of 40 to 42 weeks. The scan confirmed a breech presentation and a low-lying placenta. The device recommended referral to higher level of care. They carried out this referral, and the lady was sent to the local government hospital. Upon further examination, they identified that the mother was carrying twins. They were able to successfully conduct a C-section. Today, the babies and mother are all doing very well. At the end of September this year, a pregnant mother presented to one of our remote clinics with new onset vaginal bleeding. Fetal heart rate was still present, and so they conducted a BabyChecker scan. The device estimated a gestational age of 35 to 36 weeks and identified a low placenta. The patient was immediately transferred to the government hospital for an emergency C-section. The mother was soon diagnosed with placenta previa. Thanks to early interventions, the mother and child are both alive and doing well today. No mother should die bringing life into the world. On behalf of Jericho Road, on behalf of nursing and midwife teams in Sierra Leone, and on behalf of mothers and babies everywhere, I want to thank Delft Imaging for developing and continuing to refine this product. At the close of this speech, I want to offer up a few audacious challenges. For widespread adoption, how can we get the word out? And how can we make the device radically affordable and the supply chain adequate so that global midwives can, apart from the financial help of governments and nonprofits, be able to both afford and use the device across the global South? How do we move this device from a novel pilot to widespread adoption? Finally, what's next? The application of this device to maternal health is amazing. How else can we develop AI algorithms to help CHWs and community health nurses in local communities perform additional diagnostics related to infectious diseases and beyond? And as an example, I'm imagining a world without leprosy and better TB diagnostics. And I really believe that an adapted tool like this could help accomplish those goals. Thank you very much.
Thank you, Karlin. Thank you for your insight. It's truly fascinating to hear your experience in the field. So moving on, I would like to introduce the next speaker. Yeah, thank you. So this is Ms. Sofia Sappia. She's a PhD candidate at Radboudumc. Today, she'll discuss the science behind developing BabyChecker. So please join me in welcoming her. Sofia, you have the floor now.
Thank you very much for the nice introduction. So indeed, my talk today will be about the automatic detection of risk factors in pregnancies in low-risk settings, and my focus in particular will be about the development of the BabyChecker. I am a PhD candidate at Radboudumc, and this is the team that I'm working with, which gathers expertise in automated image analysis, ultrasound imaging, and also tropical medicine and gynecology. As we have heard today, maternal mortality is extremely high in some regions of the world. And in particular, of the 300,000 maternal deaths worldwide, 70% of them occur in sub-Saharan Africa only. And what is important to note is that given the current knowledge and technology that we have, most of these deaths are actually preventable. And this is why the World Health Organization, in its 2016 antenatal care recommendations, suggests the use of an early ultrasound scan before 24 weeks of gestation in order to identify any pregnancy complications and properly manage them. But there are some limitations to the use of ultrasound as a screening tool in low-income countries, and one of them being the high cost of the ultrasound devices, the other one, the lack of trained sonographers. And this is why with the BabyChecker, our main aim is to introduce low-cost ultrasound in combination with automated image analysis to detect high-risk pregnancies in low-risk settings without the need of a trained sonographer. And because this product has to be suited for novice operators, we have adopted the observatory protocol, which Julio briefly talked about, and was introduced by Kirsten de Stichter from Imaging the World back in the year 2011. And this protocol consists of 6 standardized sweeps over the graphic abdomen, 3 vertical ones in the transverse plane from bottom to top, and 3 horizontal ones in the sagittal plane from patient's left to right. And if we play this video, we can see an example of a midwife following this protocol and scanning the patient. Can we see the video playing? Yes. So we can see an example of a midwife acquiring data from a patient and following the protocol that with the instructions that are on the screen. And again, as Julio said, this requires no prior knowledge or expertise in ultrasound. and it can be taught within 1 hour. And the BabyChecker integrates well with the healthcare system in these settings, as in the triage system that Julio explained, in which we can see in the initial phase where the patient, this is an outreach, or the patient will go to a healthcare center, they'll get an ultrasound scan, and two possible outcomes will come out from this. Either there is no risk in this pregnancy, so we would like to schedule a next visit and the patient can go home, or else there is some risk identified, and then this patient needs to be referred to a proper level of care. So this is, in a nutshell, what the BabyChecker concept is about. And I would like to now move on to the main part of this talk, which concerns the research that was performed at Radboudumc. And for this, I would like to credit my colleague Thomas van den Heuvel, who was the main researcher working on this and whose work I'm going to be talking about today. So the first initial step for developing the BabyChecker was to test whether low-cost ultrasound devices and the obstetric suite protocol were sufficient for estimated gestational age. And for these, 60 participants were scanned using 4 devices, 3 low-cost ultrasound devices, which you can see in the 3 columns to the right of this image, and 1 high-end device that was used as reference, the Volson, which you can see in the left. And the main goal of this study was to estimate the accuracy, to evaluate the accuracy in gestational age estimation, both with images acquired with low-cost devices in comparison with the high-end device that's a reference used in clinical practice, as well as following the standardized protocol that I talked about earlier. And 2 main conclusions were drawn from this study. First, on the head circumference planes that were acquired with the low-cost devices fall within inter-observer variability reported in literature. So this is good, we can use low-cost devices. But in addition, we also reached the conclusion that gestational age can be estimated properly through the measurement of head circumference on scans acquired with low-cost devices following the obstetric suite protocol. So this led to the proof of concept of the BabyChecker as a product or as a working solution. And then it was tested back in the year 2016 in Ethiopia, and its ease of use was confirmed on midwives that received 2 hours of training. And I would like to now move on to a bit more technical part in which I want to explain how the BabyChecker works in the backend, what the AI part consists about. And for this, one of the initial steps that happens in the application is the classification of the different ultrasound images that are acquired. So we're interested in knowing the content of these images, and we classify them into some categories. For example, we see a full fetal head in the field of view. We see a partial view of the fetal head. We see parts of the torso, a side view of the fetal body, or even if the transducer is detached, that means that the probe is not making proper contact or no contact at all with the patient's skin. And anything else now falls under the other category, which we are not currently using. And why is it useful to know the content of these images? For example, going back to gestational age and explaining a bit more in depth how we can derive it. If we know which images contain a full view of the fetal head, then we can run a segmentation network that identifies all the pixels where the fetal head is. We then fit an ellipse to it and to estimate the head circumference, and through some curves, we can estimate the gestational age. And you can see here that there is a good agreement between the measurements estimated using this method that you can see on the y-axis with respect to the reference acquired in clinical practice in the x-axis. And another part, another useful case scenario for this frame classification is fetal presentation. So here we can see a video that I'm not sure if it will play on its own. Yeah, it starts playing. So In this video, we can see that in the beginning, in blue, we have some frames with fetal head, then we have some fetal torso and in between other structures, and then we can see some black parts in the image that they correspond to the transducer being detached. And this means that we have ended sweep 1 acquisition, which if you see the image on the right, you can see that it goes from the bottom, the midline, patient's midline from bottom to top. And every time we see like these dark parts, these dark images in this volume that I'm drawing here, then it means that we are moving on to another sweep because we lift the probe. And right now, this might not seem like really straightforward to you. It's not really readable for us. But what we do is we rearrange it in space in a way that we can actually understand. And that is related to both the protocol that we see on the right and closely to the patient's anatomy, because they're both closely related. And what we can see here is in blue some frames of fetal head and in green a fetal body. And we see that there are some fetal head at the bottom. And then because we know that these sweeps were acquired low in the abdomen, we know that this fetus is in cephalic lie. Analogously, in this case, we see that the opposite happens. We see some frames of fetal head at the top of the sweeps or the top of the abdomen and some frames of fetal torso at the bottom, which means that we have a case of a breech pregnancy, and this case is really important to identify because we should refer to a proper level of care. For this task, the BabyChecker performed with 100% sensitivity and 99% specificity on a test dataset containing 31 breech pregnancies. And following the same logic, in this other case, from another patient, what we can see is that we have some frames of fetal head at the bottom, so at the bottom of the abdomen, and some frames of fetal head at the top, and in between we see some frames of fetal body. So we can easily see that this cannot be the same baby. So we are in front of a case of twin pregnancies that are lying, fetuses are lying in opposite direction. And this also constitutes a risk factor that we should identify in order to refer the patient to a proper level of care. The twin detection is currently ongoing research. Because one of the challenges are, well, fetuses that lie in the same position. So you can imagine that having two heads and two torsos next to each other, then the previous approach runs a bit short. And another challenge is that in our whole data set, because of its low incidence, we have a low amount of twin cases. So we are now working towards the development of a model that can be trained mainly on single pregnancies. And we are moving on, instead of a frame classification approach, we are now working on segmentation approach, in which we segment different fetal parts. We align them in space, and through a rule-based system, we can identify each of the different fetuses and count them to know whether this is a single or multiple pregnancy. And lastly, one of the other applications that we have worked on is the localization of placenta. For this task, what we do is for every input image that we acquired, we send it through a network that performs a segmentation task, which means that it identifies all the pixels in each of the images where placenta is present. And if we render this into the whole volume, now again, you should visualize the sweep protocol and the abdomen that we have. Each of these numbers from 1 to 6 represents one of the 6 sweeps. At the top, we have the reference annotations, and at the bottom, the model segmentation. And for this task, we're currently using only the first 3 sweeps, so the vertical ones. And it's a lot easier if we visualize them but while rotating them. So sweeps 1, 2, and 3 here correspond to the orange arrows in the image to the right. And what we can see is that in all 3 of them, the placenta is located higher in each of the sweeps. So this means higher in the abdomen and in the uterus by extension, which means that this is not a case of low-lying placenta. So there is no risk, and this patient can go home and the next appointment can be scheduled. For this task, the BabyChecker performed with a sensitivity and specificity of over 80% in a test data set containing 16 low-lying cases. And lastly, I also wanted to acknowledge the clinical team and collaborations that we have. So Jeroen is also part of my supervision team. So you saw him earlier on my slides, but Anouk is an obstetric sonographer that provides a lot of input about some ideas and things that are necessary. And Camilla and Stein are research medical students that joined for internships and are actively analyzing data as well. So I would like to thank everyone for your attention.
Thank you. Thank you so much, Sofia. Understanding how the BabyChecker AI works is very interesting, I have to say that. A quick reminder to everyone, if you have any questions, kindly make sure that you post it on the Q&A box. We will have a Q&A session after everyone presents, so all your questions will be addressed. Thank you. Next slide, please. Coming up next, we have Miss Irene de Vries. Irene de Vries. She is a maternal and newborn advisor at the Kit Royal Tropical Institute. In her presentation today, which is quite rightly titled, Beyond Medical Effectiveness, What Patients, Providers, and Health Systems Need, she will discuss the intersection between the medical and social science fields, particularly how people-centered approaches and apply system-level thinking can help ensure that innovations, particularly the new ones, are adopted, sustained, and scaled well and eventually reach those in need. So please welcome her. Thank you. Please welcome Irene.
Thank you very much, Katya. Yes, my name is Irene. I'm a medical doctor, global health physician, and a medical anthropologist working for Kit Royal Tropical Institute. Before moving on, I would like to emphasize a special thanks to Amy Koroma, who is one of our Master of Public Health students from Sierra Leone. Amy did her thesis on the BabyChecker pilot project in Sierra Leone, exploring the experiences of healthcare workers and clients in Tonkolili districts. And this presentation also partly refers to her work, so hence my thanks. On the picture that you see here, you see Amy on the left next to the DMO of Tonkolili districts and also Enia Seguin from BabyChecker. Next slide, please. Yes, it has already been said. The World Health Organization recommends one ultrasound before 24 weeks of gestation for pregnant women to estimate gestational age, improve detection of fetal anomalies and multiple pregnancies, reduce induction of labor for postterm pregnancy, and improve a woman's pregnancy experience. Evidence does show that women are willing to be screened and tested for a variety of conditions, that they appreciate the knowledge and information they can get, and that offering ultrasound services may lead to earlier ANC attendance, all if services are delivered in a caring and culturally sensitive manner. However, globally and even nationally, there are major inequalities. Various factors influencing accessibility make that in many resource-poor settings, antenatal ultrasound is only available to a privileged few, often in urban centers. These factors include, but are not limited to, distances to facilities, lack of skilled ultrasonographers, lack of scans, infrastructure, and inadequate power, poverty and need to pay, health illiteracy, and cultural beliefs and traditional norms that affect access. Innovations that facilitate task shifting and bring services closer to communities, like the BabyChecker, can address some of these barriers, but remaining barriers need to be considered and addressed if we truly want to contribute to universal health coverage. That's why we collaborate with Delft Imaging to co-design implementation studies that contribute to appropriate and holistic implementation. This means it's not only about the structure that is being provided, being the device and training of providers in using the device, but also about the processes around care provision, referrals, and quality control in order to achieve the best outcomes. This is what we refer to as the quality of care approach, grounded in the theory of Donabedian. Let me provide some examples about what should be considered in the process. In the study conducted by Amy, we found that some healthcare providers were using the BabyChecker as a substitute to standard care. As one of the healthcare workers said, and you can see that in this first quote, the scan works so well that now we are super attached to it. I'm worried that we are depending on it for almost everything. What happens if it gets faulty or is not available? we are losing our skills in the process. So this demonstrates the need to continuously train healthcare providers on comprehensive ANC and use the innovation to complement and not replace existing routine maternal care interventions. It was also found that while grasping the device basic functions is straightforward, linking the diagnosis to the appropriate action necessitates certain technical expertise in midwifery and obstetrics for meaningful result interpretation. So a lack of critical thinking raises a potential risk of healthcare workers fostering a false sense of hope among clients if proper education is not provided. Another quote from a pregnant woman you can see here indicates the importance of training providers in appropriate counseling. This woman said, "No counseling was done before or after the scan was done. We assume the baby is fine if we don't hear anything from the nurse. If your baby is not well, the nurse will refer you." So what I'm intending to say is that training on appropriate counseling as part of maternal healthcare interventions is key and remains key in delivering appropriate and respectful care. Next slide, please. Barriers to referral for ultrasound diagnosed complications is another concern, leading to ethical questions on providing a patient with a diagnosis that she cannot be helped with. In the first look study by Franklin et al. That was conducted between 2014 and 2016 in 5 countries to assess the impact of ANC ultrasound on pregnancy outcomes in women residing in LMIC, 29% of the women who were referred did not attend the referral due to disapproval by community members or previous bad experiences with the hospital, barriers in cost, transportation, and distance. And also after reaching the hospital, substantial barriers were identified, including not being connected with an appropriate provider, not knowing where to go, and being told to return later. Next slide, please. Factors that enable successful referral are appropriate communication, including description of the ultrasound findings and the reason for the referral, providing a referral card, describing where to go in the hospital, and explaining the procedures at the hospital. It indicates the need for implementation of ultrasound devices to work alongside health system strengthening with the requiring enabling environment, strengthening of referral systems, and quality throughout the continuum of care. The final process example that I want to give you is the one on quality and control. Equipping close to community providers with point-of-care ultrasound devices can work empowering and have an income-generating effect. However, previous studies have also indicated how the absence of proper supervision and guidelines for practitioners may create an environment for misuse and abuse, and therewith potential harm to the patients. For example, by offering ultrasound for inappropriate indications, non-evidence care, offering too many ultrasounds and charging patients for it. Quality ultrasound services and training require political will and local governance to regulate services and assure quality. This means that appropriate guidelines should be in place on who should provide the services, the required level of training and certification, and appropriate supervision to avoid overuse, underuse, or abuse. A regulating authority where professionals and facilities providing ultrasound services are registered and quality assurance of the services monitored and controlled will improve the quality of services. This also implies the use of second opinions and continuous education for all practitioners. Next slide, please. So, in conclusion, communities, providers, and health system factors interfere with medical innovations. Implementation studies are needed to ensure these factors are studied and addressed to ensure we achieve universal health coverage and deliver holistic quality care. Thank you.
Thank you. Thank you so much, Irene. That was quite fascinating. So now, next slide, please. Yeah. Now I warmly welcome Mr. Jose Perez. Jose is the UNFPA representative in Honduras. He has worked with the UNDP as a program officer in poverty reduction and Millennium Development Goals. And he was also in charge of the Human Development Report for Panama in 2014. That's not all. Prior to working as a UNFPA representative in Honduras, he was a representative of the UNFPA in Panama. So without further ado, I welcome him to talk about BabyChecker's journey in Honduras. Welcome, Jose.
Thank you very much, Katya. First of all, I'd like to thank Delft and Katya, Julio, and especially Enya, whom we've been working with in the past year to make this possible. First slide, please. Well, excuse me, before I start, I'd like to first mention something about UNFPA. UNFPA, or the United Population Fund, is the sexual reproductive health agency of the United Nations. And we are focused on basically 3 transformative results, which are 0 preventable maternal deaths, 0 unmet family planning needs, and 0 gender-based violence, many times related with sexual reproductive aspects. How it all started? Well, in November 2022, I had the pleasure of hearing Enya's presentation on a webinar about the role of artificial intelligence in achieving good health and well-being. UNFPA has been very adamant about looking at innovation as a way to leapfrog and advance in many of the issues in reducing preventable maternal deaths. And when I saw this, I thought that this was a wonderful possibility of maybe reaching out and seeing the importance of bringing the equipment to Latin America, and especially to Honduras, because of many of the issues related with maternal deaths due to extensive areas in Honduras that are very far to reach, where most maternal deaths occur to a certain degree. So we started exploring the possibility with BabyChecker. We went to the Ministry of Health, and also we explored the possibility with midwifery groups in the Garifuna-Orlenca region, which is the far areas. Next, please. Just to give you a brief country context, Honduras has a population of 9.3 million. 60% are under 30 years old. And in that reality, Honduras has been very much affected by national environmental disasters, hurricanes, and whatnot. So 2.8 million of the population is in need of humanitarian assistance. When we look at many of the ratio of maternal mortality, from 61 per 100,000 live births, it shot up after the pandemic to 125. And this really perpetuated a situation that was very critical for us. And one of the issues was the institutional care, which was the causant of many of maternal deaths. So just to, and in a very, also high levels of poverty, which are another element that perpetuate many of these difficulties. Next, please. So we strategized an institutional approach, and what we did was first we compiled data on the most critical areas in the territory. We analyzed the main causes of maternal mortality, and half of them, curiously, were related with women who had even up to 4 antenatal care visits. So this was really shocking, because normally it was much less the antenatal care provisions that would generate maternal deaths. But then we also looked at there was low quality medical attention in these visits. It's not so much the number, but the quality of the care that was given. So if you went to an antenatal care visit and you didn't have the reagents to do the medical test, if you didn't have the equipment to do it, or simply there was not a good arrangement with the participation of the medical staff, then you would have difficulties. Also, lack of professional medical staff in remote areas and well-trained personnel, definitely. And on another case, there was overcrowding in general hospitals. So many medical appointments were unfortunately not being able to be done because they had to postpone the visits. And of course, as someone mentioned before, the cost for a woman traveling from a rural area to a general hospital is a factor that deters maybe the possibility of searching or looking for better care. Next, please. So when we looked at in the year 2022, there were 83 maternal deaths. Funny enough, it was, well, funny enough, not. Basically, it wasn't due to community deaths, it was more institutional deaths. So part of the issue was what was happening with the quality of care and what was happening at that, the critical route to be able to attend women. Next. And as I mentioned before, out of 45% of those cases, women had already 4 and more antenatal care. So this was a reflection of what was happening to the quality of care. Next. So when we got in touch with Delft, one of the initial questions to get started and to basically move forward with this collaborative effort, which we want to basically test the use of BabyChecker in Honduras and see its applicability and of course the many benefits that it can offer. Well, we saw what was the rate of antenatal care. Not going to go into details. What was the rate of detection of other diseases that have complications? And it's important to note that in certain areas of Honduras, there is a lot of difficulties with yellow fever, malaria, and other elements that also can affect the safety and the health of pregnant women. How many referrals were advised during the study? Next. And we went through basically what was the rate of antenatal care visits per client, how many rescans were advised, and what was the performance of non-clinicians using BabyChecker. So with this basis and this framework, we went to the Ministry of Health. Next. And we basically we were doing advocacy, let's say, for overcoming the resistance to artificial intelligence. As you can imagine, in many areas of the world, of course, artificial intelligence is being demonized in certain aspects, but very specifically in the medical field, it is very important. And we see the capability to improve the quality of care that medical personnel can provide because of all the benefits it has. So we presented the idea to the Minister of Health in an informal lunch. And this was not making it overly, formal, let's say, to explore the possibilities. We also did that. We invited the Dean of Medical School of the University of Honduras to talk about it because it was important to start showing this as an alternative to incorporate in the curriculum in the formation of medical doctors and medical personnel in the country. And there was, of course, this is not going to displace doctors or medical staff. Many of the elements were, well, it's not reliable, is it secure? And basically what was explained was the use of algorithms that would allow to be able to hone in and be much more precise. And in the more that we would use it, it would allow for us to be more specific. And it was a perfect opportunity to incorporate this and not be resistant against it. Cost versus utility, definitely the cost of this equipment compared to standard equipment is one thing. And of course, access, versatility, and connectivity were issues that made a strong case for it. Next. And it was important, and I'd like to make sure that there was also internal and external red tape, bureaucratic procedures. On one hand, the Ministry of Health had to do legal reviews and acceptance on behalf of the ministry before we brought in the equipment because, of course, they would have to be incorporated and part of this. And on the other hand, even internally within the UN, with our all the need for our units that basically is the supply chain and management unit, it's called. When we were going to buy them, they would say, well, what is it exactly? Have you done an open procedure? Have you? And we explained, look, there are not many equipments like this in the world, so we can't go out and do a bidding process because it's not easily available. And this was one of the elements that we had to work on from inside. Next. So how do we intend to use BabyChecker? We're in the phase that we've received the equipment. We're working with the ministry, getting everything ready for the protocols that will be installed. And we purchased 5 units, and 3 of them will be deployed to faraway areas that basically require, they have no special personnel. And the advantage of the early detection of potential complications will be critical to reduce maternal mortality in these areas. But we are also going to use 2 of these units in the main hospitals that turn the largest maternal wards, so we can get a much further capacity to analyze and use the equipment locally, and also do extension work with students and the medical faculty here in Honduras. So this is where we are right now. And once again, I'd like to highlight the excitement and as Julio said, how to transmit the compliance. And we're very happy to be involved. And we foresee much benefits for the benefit of the most left behind populations in Honduras. And thank you very much.
Yes, thank you, Jose. And first, quickly, briefly, before we dive into the Q&A sessions. It's a lot of questions, I think, that were already posted. So my colleague Julio will tackle all of those in a second. Our side. I saw my sound was muted for a second, but the big thanks to all of our speakers for being here today, for making the time, and to talking to everybody who was able to dial in today about today's topic. I think it's very interesting. I think in line what you, Jose, were mentioning at the end, you know, in terms of the facilitating the procurement process, like nobody is really doing this, and I think that's what makes it very exciting, and that's the part that's of course very very new, and that we're all very excited about to see how that's going to move forward from both the implementation side and of course also the research side. That being said, I will hand it over to my colleague Julio to take us through some of the questions that were asked, and also see if any other new ones popped up.
Thank you very much, Florent. So, well, again, thank you very much, everyone, for joining. I will proceed with the questions. There are several questions that have already been answered, like related to the limitations related to twins, to multiple pregnancies. There was an interesting question about the CE approval and the USBA and the FDA approval. Like, we are currently on the process of regularization regularization, and the profit certified, and artificial intelligence will also be at some point certified. We are working on that very hard. We currently are doing all our work in the States with all our projects. We have analysts also remotely reading the images to make sure that the artificial intelligence, it's not the only source of information over there. We also have trained personnel behind verifying everything right now at this moment. The gestational age that BabyChecker work, the artificial intelligence currently work from 12 gestational age and above. However, again, like thanks to our remote analysis, we are also able to analyze earlier gestational ages. The report of the ultrasound, like I will want to ask a little bit more about that, because I'm not sure exactly what do you want, but it's a feature that it's not currently present in BabyChecker, but if it's needed, or if we see like it has a useful, we could definitely add it to the product. The ectopic pregnancy, I think Sofia answered that very clearly. Like currently we don't have anything related to ectopic pregnancy. There is no development, and there is also very little data that contains this kind of ectopic pregnancies. This makes really difficult to train any artificial intelligence, and it's one of the main limitations as well for artificial intelligence. Like we need data. And also, for example, for the multiple pregnancies, like currently in our research places in Africa, like there is very little multiple pregnancies that we are receiving. And we are working, as Sofia said as well, in different ways to approach these problems to be able to overcome them. Jose also answered very clearly the regulatory registration in low resource settings. Thank you very much for that, Jose. Like, I think it is, yeah, in currently, like, yeah, in most of the places, like, I don't think there is a need for that. It's not clear still how it's that being done. And in, like, yeah, with artificial intelligence, it's something really new. Like the European Union, it's catching up slowly, the FDA as well, and at some point there will be more clear steps to go forward in that. Like, please, if you feel like you want to add something, any of the speakers, like, please feel free.
I can add to that.
Yeah.
Yeah, maybe to add to that. So most of the cases, of course, in the case of research projects or validation, there's waivers applicable for the local registration. There are countries where there's either local registration requirements or local import requirements, which we tackle on a case-to-case basis. And basically for every country, we're seeing, once we've started implementing, you know, also research projects before, that also helps with the registration afterwards, because you have a good case study already in country to build up for the registration. So I hope that that clarifies that question a little bit, and I'll give it back to Julio.
Then related to, for example, like how are the results of the scanning shown on the smartphone? Like currently we are mentioning the different risk factors separately. This means that, for example, of course, like we currently do the green, yellow, red. Red is, for example, if there is multiple pregnancies, those are always referred. Also, for example, if there is a low placenta, when the gestational age is larger than it's above 28 weeks, because then the possibility of that placenta to move will be low, and then that will definitely should be referred as well. And for the rest of the cases, for example, if we have a low placenta with a window between 21 to 27, I think it is on the top of my head, like that will be yellow, that we will recommend a scan to happen earlier than it should happen. And in other cases, it will be green and it should follow the procedure as normally it should happen. Like also to mention that all the answer sheet is gonna be available after the Q&A finish. So if there is any question that you are not missing, it will be answered and it will be sent. Are we planning to do any studies in the US or EU? That could be a possibility. Currently, our artificial intelligence is trained on African data. It's mostly all the data that we have been acquiring. So it will be definitely interesting to see how it can generalize to data from EU as well. Probably Sofia can answer a bit more over that. Could this device be used by non-professional personnel? Yes, definitely. They could be used, but this is also something that Irene mentioned as well, that it's clear that not everyone should be using this device without a proper training. It could be used, the device, with the training that we currently have in the application, and the easiness of use of the application will allow anyone to use the device and provide using artificial intelligence. But definitely it's something to have in mind. BabyChecker is compatible with any Android phone at the moment. We don't do iPhone because compatibility with the probe that we have at the moment. And also for easiness, of not really easiness, but like most of the low resource settings that we are working and developing countries, Android is the main phone that it's being used, and it allows it to have more reach.
Julio, you mentioned my name, but I was just busy typing an answer, so I don't know exactly what you wanted me to expand on. Maybe you can.
I think someone already answered it.
Okay, good.
Is the reason for the low high risk assessment result given, or just so there is a reason, of course, like we give, like if there is a low placenta, we mentioned that there is a low placenta. If the fetal position it's unbreached, for example, we also provide the reason over there. So there is always a clear reasoning. It's not only red, yellow, green. Like we clarify why the application or the analyst deem that pregnancy risky or not.
Yep.
Is there any other questions that I see messages here? So I'm seeing one question in the webinar chat, not in the Q&A. Like we are working currently on doing amniotic fluid detection abnormalities. We currently don't do or don't have anything related to congenital fetal anomalies, but definitely like any features and risks that could be detected, like we will try to see if it's possible to do them with artificial intelligence, and if it's possible, add them to the application. But at the moment, like we don't detect right now those.
Yeah, can I briefly expand on that?
Please.
Yeah, so also we try to take into account which kind of risk we want to detect, and it's very useful to talk with tropical doctors that let us know which kind of risk can be properly followed up, because you can imagine that you do not want to tell a person that they have some congenital abnormality if there is no proper follow-up available in that setting. So we're always very careful at which kind of risks we want to develop that makes sense, and then we don't just give bad news, which could also lead to more problems, or it could even be sometimes unethical to detect some things, because some decisions might be made by the patients. For example, if someone has an abnormality and they don't want to go on with the pregnancy, that might imply a risk if they opt for abortion, which is not legal and safe in these settings. So for all of this, we always try to get advice from tropical doctors and what is relevant.
Well, with this, thank you very much, Sofia, for expanding on that. With this, I think we are concluding the Q&A, and I'm leaving the word to Katya for the final part of the webinar. Thank you very much, everyone.
Thank you. Thank you so much, Julio, for answering all these questions. I can already think of some myself, and I'll make sure to ask you afterwards. And I apologize to anyone if we have missed any of your questions, but rest assured, please make sure that you share it with us afterwards. We will make a point to answer them as soon as we can. We will be sharing the Q&A sheet with all the answers that we just discussed, alongside the recording of today's webinar. This webinar will be available not only in English, but also in French, Spanish, Russian, Arabic, and Portuguese. So you will get the recording soon. Thank you, everyone, for attending today's webinar. I'd like to especially thank our speakers. Thank you so much for making the time today, for thinking this was important enough. Thank you so much. I would also like to thank my production team, my producer, my colleague Chow, Ian Chow, thank you so much. Our interpreters who did a wonderful job today. Thank you so much, guys. We don't know what we'd do without you. And of course, I'd like to thank my colleagues, Florent and Julio, who joined us today and made this all the more better for us. Thank you so much. I hope you guys have a wonderful day ahead of you. Already we are wrapping up 15 minutes early, so that's the best, right? Thank you so much, guys. I hope you all have a wonderful day ahead. Thank you.